having good time at your home. Okay, so today our topic is this intelligence spondylitis, and I will try to just focus on the topic because you see a lot of patient who comes to you with history of joint pains and involving the hands, your wrist joint, your elbows, shoulders, back pain, and even your knee and ankle joints. You have to make sure what type of this arthritis is, whether it is a rheumatoid arthritis, it is a small joint involvement or large joint involvement. In rheumatoid arthritis, which is seropositive arthritis, you see there is a bilateral symmetrical involvement of the joints, mostly starts from the early morning stiffness and involving gradually the small joint leading to large joint involvement. So bilateral symmetrical peripheral joint involvement is a most likely feature of rheumatoid arthritis. In reverse to that, ankylosing spondylitis is a disease which is a chronic inflammatory disease of the axial skeleton joints. Means you can have that disease process which is a chronic inflammatory process involving the sacroiliac joint. First, it causes the sacroiliac joint, and then your spines are gradually involved, leading to stiffness and deformity and reduced motion, especially the back motion. So ankylosing spondylitis is a bad disease, very rarely found, but mostly of the disease of the young. It is a young disease, sometimes used to be known as Bestier's disease or Bestier's syndrome. And that syndrome means this arthritis, which is a seronegative arthritis. Seronegative means rheumatoid RA factor is negative. So seronegative arthritis, that is also known as the large joint involvement, especially the sacroiliac joints and the spines. So usually you will you will be in your OPD or you will see a patient. Usually it starts from the young age group. In teens, means it starts from 15 to 30 years. Young males are more commonly affected than females. Young male with history of chronic backache. Backache means he has got pain in the back, which is worse early morning. जैसे just like rheumatoid arthritis, the hands become stiff, difficult in stiffness of the hands in rheumatoid arthritis. In ankylosing spondylitis, because it is ankylosis and spondylitis, I'll explain what is ankylosing spondylitis. So sacroiliac joints and lower lumbar spines are the first manifestation presenting with the lower back ache, and patient will have early morning stiffness, and this is the characteristic feature that patient gets better after exercise when he starts his day routine work and he gets better. So early morning backache with morning stiffness is a first, usually the first presentation. So the ankle spondylitis used to be a Dachshire disease. So it is a form of arthritis that is a long-standing chronic and most often affects the spine. So axial part of the skeleton joints are most commonly affected. So it affects the joints in the spine and the sacroiliac in the pelvis. So sacroiliac joints and the lower spines are the most common first presentation. Present with chronic backache that is worse in the early morning and gets better after daily routine, after exercise, or even after some time. That is a very significant feature, early morning backache, and gets better after exercise. And you will see the patient who are young people with early morning backache, and they can have a syndrome that can lead to involvement of the spines, the sacroiliac joints. Even it extends ephelically. Means your lumbar spine or sacral areas are first involved, then it extends proximally involving the thoracic spines, and I will show you the picture involved leading to deformity of the thoracic spines, and the patient will have At the same time, systemic manifestations like they can have complications like cardiac complications and other complications. These are the sacroiliitis can also be seen in patients with enteropathic arthritis like ulcerative colitis, Crohn's disease. They usually can have sacroiliitis. So it is a chronic disease involving the axial joints, that's mainly the sacroiliac joint and the spine. And sometimes this chronic inflammation leads to complete fusion of the spines, leading to a bamboo spine. The bamboo spine, you have a rigid, calcified uh, spines. Patient has difficulty in movement on other side, even on bending. So they have a very bad stiff spine, and they cannot move even side to side, and especially the bending is very problem, and they can lead to deformity and specific posture that is a common sign. A patient have bad kyphosis, and you can have thoracic deformity at the same time. So it is a systemic rheumatic disease known as seronegative arthritis. So rheumatoid arthritis is a seropositive arthritis, and it is a seronegative arthritis, meaning RA factor is negative. And the characteristic manifestation is it is a disease of the youngs. I told you it starts from the maybe 18 to 30 years. So young man comes to you with history of chronic backache, and he will say, I have difficulty when I wake up, very stiff back, difficulty in movement, and it gradually gets better over the day. So men affected are more than in women, and ratio is about 3 to 1. So males are more commonly affected as compared to females, and males have a bad prognosis, leading to postural abnormalities and limitation of spinal movements. So what are the factors which can cause ankylosing spondylitis? So this is a disease which is a chronic inflammatory disease, and the cause is unknown, but there are a lot of factors which can lead to inflammation of the sacroiliac joints and the other joints, other spines. So genetic predisposition is a definite. People who have a history of ankylosing spondylitis in their family, they have high risk of getting the disease. Another important feature is the HLA-B27. This is the hallmark of the patient with the ankylosing spondylitis. They can have RA factor negative because they are seronegative arthritis. So only specific diagnostic test is HLA-B27, which is almost more than 90% patients are positive. And they also have a tumor necrosis factor, means the interleukin factor. These are the chronic inflammatory markers which lead to inflammation of the spine, sacroiliac joints, and leading to chronic inflammatory process with damage to the spine and leading to bamboo spine and stiffness. So what is HLA-B27? It is a human leukocyte antigen. HLA human leukocyte antigen, which is a specific subtype of B2702724. So it is a class 1 surface antigen which is encoded in D locus in the major histocompatibility complex, that is major histocompatibility complex chromosome 6, and it has a very antigenic to stimulus to T cell, which are strongly associated with a certain autoimmune diseases. So it stimulates the T cells and leading to an autoimmune process, leading to inflammatory process, and that leads to ankylosing spondylitis and the inflammatory disease of the spines. So this is a HLA-B27 is the hallmark, the diagnostic test of ankylosing spondylitis. Another theory is tumor necrosis factor. This is a TNF. Tumor necrosis factor is also is a cytokine involved in the inflammatory process, and that leads to regulation of the immune cells. And tumor necrosis factor is also used causing apoptosis of the cell and inflammation and inhibit the tumorigenesis and viral replication. So this is another inflammatory marker that goes on side by side, leading to inflammation of the spine, sacroiliac joints, leading to damage and leading to kyphosis and limited leading to stiffness of the joint and deformity leading to bamboo spine. Interleukin, again, the markers of inflammatory cytokines that involved in the immune defense against infection. Interleukin 1 is the molecule that competes for receptor binding the interleukin alpha and beta, blocking their role in the immune activation. So these are the three major factors that are involved in the inflammatory process of the axial spinal spines of the body, leading to damage and deformity and kyphosis. So HLA-B27, tumor necrosis factor, and interleukins. These are the three markers of inflammation that leads to damage to the spine. Okay, so what happens when you have high storm of inflammatory process in the body? And what happens is your spines, if you look at the normal spine, you can see the vertebra, the intervertebral space, and the discs. What happens is your inflammatory process takes place in the ligaments and your joints. So these two processes, the ligaments and the joint, they become inflamed, leading to the damage of the joints and the your intervertebral spaces. They are inflamed, they gradually diseased, and they are damaged, leading to your bone protrusion. You can see that small syndesmophytes are formed. These are the small bony protrusions which appear in their spinal processes and leading to square side. This is the vertebra becomes square. They are fused together and leading to loss of intervertebral discs are lost, intervertebral spaces are lost, and the spine become fused together and leading to limited movement and lateral calcification and leading to bamboo spine. So this is the fusion takes place. So if you look at the inflammatory process, look at the good vertebrae, and this is the you can see the bony prominence. Syndesmophytes are formed due to chronic inflammatory damage to the vertebra, and you have a joint damage leading to stiffness and loss of movement. And then you can see that syndesmophytes, they are formed and the vertebra they fuse together and form a stiff spine, which is having limited movement. Patient will have pain because of the inflammatory process and limitation of spinal movement. This is a very, you can see the fused spine, they are fused together and you look at
एमएसपी को मैंने कहा यार देखो मैंने कहा ऐसे साइंटिस्ट उसका बन जाता है
and
प्रोफेसर बनाना चाहे
hello, and you can see that this is the normal vertebra. You can see that this is the fused vertebra in the process of, you will see the disc is lost, vertebra fused together, and the calcification takes place, and these two vertebra are fused together, leading to loss of movement and deformity takes place. And this is the typical form when you have a kyphosis and your leading to a coma posture. Okay, so signs of inflammation, you can have bad severe backache and leading to radiating to the thighs, vertic radiation to thighs. Patient will say, I'm very in severe pain when I wakes up early morning and my pain radiates to the thighs, buttocks and thighs, and worse in the early morning. The pain gets better when I take some activity, I do my normal routine work, and pain gets better. This is a specific feature of untitled spondylitis. In reverse, a patient with degenerative diseases like osteoarthritis, patient with other diseases, they get worse after movement. But this disease, untitled spondylitis, gets better after activity, and it is a bad on patient when resting and wakes up early. So this is the only differentiating point. Backache because of spinal problem, because of spinal disc protrusion or disc collapse or degenerative disorder, that pain is worse on movement. By ankylosing spondylitis, the pain is worse on rest and gets better on movement. Okay, so what are the early feature symptoms? Patient will have chronic backache, stiffness, and tenderness of the back muscles. I told you the patient will have sacroiliitis, and patient will have pain in the lower back and related to the thighs. And there may be A flattening of the lumbar lordosis is your normal curve of the lumbar spine is lost, and patient will have bilateral sacroiliitis, your sacroiliac joints. Okay, another feature is this disease causes bilateral sacroiliitis. It's a symmetrical disease involving the sacroiliac joints. While patient with Crohn's disease and enteropathic arthropathies like Crohn's ulcerative colitis, Behçet disease, or patient with other disease, they have a unilateral sacroiliitis. These are the patients, they have a bilateral sacroiliitis. Another pathological process is the enthesopathy. These are the pain site ligaments, and they are attached to the bone, especially the iliac crest and the trochanter, spinal process of the vertebra, the costovertebral joints. The ligaments, which are especially the Achilles tendon and the plantar fasciitis. This is the enthesopathy is the inflammatory process leading to inflammation of the ligament attached to the bones. So most of the major ligament is the sacroiliac joints, the trochanters, spinal process of the vertebra, and costovertebral joint. Also the Achilles tendon, which is the biggest joint and tendon in the body, Achilles tendonitis and plantar fasciitis. So these are the patients which have pain in their backache and also limitation of movement at their limitation of activity. Extra-articular manifestation, they usually involve there is a iridocyclitis, a DD uveitis, and bilateral acute onset usually takes affects the eyes are involved in ankylosing spondylitis. So extra-articular manifestation we discussed, they have eye iridocyclitis, uveitis, usually bilateral, maybe unilateral, but usually bilateral, and that can see in patients with ankylosing spondylitis. So backache with ligamental inflammation involving the iliac crest, trochanters, and your Achilles tendon and plantar fasciitis. These are the clinical manifestations, and extra-articular manifestations, especially the eyes, they can lead to iridocyclitis, anterior uveitis, and loss of vision. Other features, patient will have pain, different segments of the spine. They may have abnormality like question mark posture. So this is a very typical feature of ankylosing spondylitis, leading to there is a increased prominence of the thoracic spines, outward and inward protrusion of the lumbar spine, and there will be associated atrophy of the back muscles, decreased thoracic excursion, and patient will have decreased expansion of the lung, may lead to respiratory distress, and these are the patients who have biapical involvement of the lungs. So because of the costovertebral joint involvement as an inflammatory process, these are the patients who can have back chest pain and the limitation of thoracic movement and leading to respiratory distress. Decreased articulation of the spine and ankylosis of the sacroiliac and intertendon joints. Cutaneous manifestation can take place, but most important is the cardiovascular and the gastrointestinal and urinary manifestation. In cardiovascular system, ankylosing spondylitis, so it is an inflammatory process that can lead to aortitis. Aortitis leading to aortic regurgitation, aortic insufficiency, and patient can have pericarditis and myocarditis. So it is a inflammatory systemic disease rather than a syndrome, mainly involving the axial part of the skeletal system, your spine, sacroiliac joints, and extra-articular manifestation involving the eyes, the cardiovascular system, especially aorta is involved leading to aortic dilatation, aortitis leading to aortic regurgitation, and may cause pericarditis and myocarditis. Like I told you that because of the inflammation of the costovertebral joints, these are there will be bronchopulmonary involvement and leading to decreased excretion of the lungs, decreased chest expansion, and fibrosis of the apical segment of the lungs. And there is a high risk for infection. Urinary system chronic, because it is a chronic inflammatory disease and involving the joints, but at the same time, as a part of chronic inflammation, it can lead to amyloidosis and a nephropathy. Amyloidosis means there is amyloid proteins get deposited, like patient with a bronchiectasis, patient with a chronic diseases like tuberculosis, can lead to secondary amyloidosis. So amyloidosis may be primary or secondary. So this is a secondary amyloidosis because of the chronic inflammatory process as part of ankylosing spondylitis. So amyloid protein get deposited in the kidneys and they lead to proteinuria and renal failure. At the same time, they can have IgA nephropathy. Gastrointestinal tract, they can have ulcer. I told you it is a part of enteropathic arthropathies. Enteropathic means intestinal diseases leading to joint involvement. Enteropathic arthropathies, especially patients with ulcerative colitis and Crohn's disease, will have sacroiliitis or involvement of the sacroiliac joints. Extra-articular manifestation again will see the ocular, where you will have interior uveitis, cardiovascular aortitis leading to aortic regurgitation, myocarditis, and you can have conduction defects, even AV block. Gastrointestinal, you can have colitis like Crohn's associated and ulcerative colitis associated, and cutaneous, you can have postural psoriasis. Postural psoriatic rash can be a part of your spondylitis. Pulmonary manifestation like typical fibrosis and renal involvement leading to amyloidosis. So, ankylosing spondylitis is a chronic inflammatory process involving the spine, sacroiliac joints, and part of extra-articular manifestation may present with the features of deep shortness of breath. You will have palpitation, and you see he has flexing pulse, the regurgitation is there, and you do the chest X-ray, you can see the apical fibrosis of the lung. So patient had ankylosing spondylitis. Now you see there is involvement of the extra-articular complications. So one syndrome involving the burden of the disease to the spine, at the same time involving the extra-articular manifestations. If we look at the anterior uveitis and uveitis, iridocyclitis, so there is inflammation of the front part of the eye between the cornea and the lens, and it is seen in 20-30% of patients with ankylosing spondylitis. Patient will have severe eye pain, uh, that sensitivity to light, flushed eyes, red eyes, and blur because of the corneal edema, and they lead to blurred vision, and there may be spots in the field of vision. So usually it is all in 2 to 3 months with residual, sometimes lead to residual impairment. Patient can have superadded infection leading to hypopyon, synesthesia, cataract, and glaucoma. The treatment is, if you have a patient with ankylosing spondylitis with anterior uveitis, you put them on steroid, antibiotics, and pediatric eye drops as a part of glaucoma. Avoid the sunlight because you can use the sunglasses. So this is the local treatment of the patient who have anterior uveitis in combination of ankylosing spondylitis. And cardiovascular manifestations, I told you, these are the patients who can have aortitis. This is the aortic root. Your ascending aorta becomes inflamed, dilated, leading to regurgitation of the valve. So aortitis, aortic insufficiency leading to aortic regurgitation, and you can see during systole there is a blood is going out during systole, but during diastole, if you look, there is a regurgitation of the blood. This is aortic regurgitation because of the dilatation of the aortic valve ring as part of aortitis. So these are the patients who can have pericarditis, myocarditis, and AV blocks. So this is seen in patients with 33% of patients with ankylosing spondylitis, and you can investigate by doing ECG, echocardiography, and CT chest. And definitely you will consult your cardiology colleague to have a look and see the complication. So basically, ankylosing spondylitis is a chronic inflammatory disease involving the sacroiliac joints, spines, leading to stiffness and limited activity, leading to calcification and deformity, bamboo spine, and all those manifestations involving the sacroiliac and vertebral your spines. Apart from this, it is a syndrome. That means it is going to affect the other part of the body because of inflammatory process. It's going to affect your heart, it is going to affect your eyes, going to affect your lungs because of the costovertebral joints are inflamed, they decrease expression of the chest, expansion is reduced, patient may lead to apical fibrosis, and as part of chronic inflammatory process, it can lead to renal amyloidosis, leading to renal failure and IgA nephropathy. So these are the articular and extra article manifestation in patient with ankylosing spondylitis. Gastrointestinal manifestations, I told you, these are the patients who have Crohn's disease or ulcerative colitis. They have enteropathic arthropathies like at the same time, it is not necessarily patient ankylosing spondylitis is going to have ulcerative colitis Crohn's disease, but patient with ulcerative colitis or Crohn's disease can have sacroiliitis. So this is the association of the diseases. One disease can have other manifestation. So inflammatory bowel disease is a group of inflammatory condition of the colon and small intestine, which is Crohn's disease and ulcerative colitis, and it is associated in 5 to 10% of patients with Crohn's disease and ulcerative colitis can have 5 to 10% can have ankylosing spondylitis. So enteropathic, arthropathic involving with the sacroiliac joints. If the patient will have abdominal symptoms of Crohn's and ulcerative colitis, and diarrhea, rectal bleeding, severe internal cramps, weight loss, anemia as part of your GI manifestation, and patient may have toxic megacolon. We already discussed ulcerative colitis and Crohn's disease complications with malabsorption, abscess formation, fistulas, and other complications of Crohn's disease. So, patient with enteropathy, arthropathy, with sacroiliitis, and patient simply ankylosing spondylitis with intestinal manifestation. I told you the pustular psoriasis is another cutaneous manifestation in patient seen in patient with ankylosing spondylitis. So patient may have skin rash, or patient may have aortic regurgitation with a chronic backache. Backache may be ignored. Okay, I was having severe backache. No, I have shortness of breath, I have skin rash. So different presentation of a disease can be different. And sometimes you have to link one symptom or one clinical sign to the other and make a one diagnosis. So this is very important to make a correlation of the symptoms and signs to make a one diagnosis. So these are the pulmonary manifestation. You can see the apical fibrosis because of the reduced expression of the lungs, because of the involvement of the costovertebral joints. Your lungs become stiff. They are your rib cage is stiff because of the inflammation of the costovertebral joints, and lung expansion is reduced, and you can have apical lung fibrosis. You see, you can very easily see the apical fibrosis of the lungs. And this is prevalent in large number of patients. Patient may present with cough, dyspnea, and develops in nearly 50% of patients with acute spondylitis. And especially patients who have apical lung involvement do not pulmonary tuberculosis, and that may be a patient who is immune compromised, maybe a patient of acute spondylitis, and now he has a cough with expectoration, maybe hemoptysis, and you find there is some cavitary lesion or apical fibrosis. He may be on steroids or immune modulating drugs leading to pulmonary superadded pulmonary tuberculosis because he was immune compromised on immune like azathioprine or other drugs which are used for ankylosing spondylitis. Now he had apical fibrosis and now he has a superadded tuberculosis. So it's better to rule out any superadded infection like tuberculosis. The renal, I told you, renal complication as part of chronic inflammatory process can lead to renal amyloidosis. Renal amyloid protein get deposits in the glomerular capillaries, which lead to proteinuria, albuminuria, and leading to nephrotic syndrome. IgA nephropathy is deposition of IgA antibody in the glomerulus, and that is going to cause a acute nephritic syndrome. So nephrotic syndrome is proteinuria, edema with hypolipidemia and hypercholesterolemia, and maybe have pleural effusion, ascites, or edema. Maybe have anasarcia. While IgA nephropathy is a nephritis, it is an inflammation and of the kidneys. That is the nephrotic because of the membrane defects leading to proteinuria. And this is nephritic syndrome. Patient will have hematuria, will have high blood pressure. So hypertension with hematuria with proteinuria is a feature of is it IgA nephropathy, and patient with nephrotic syndrome feature of proteinuria with edema is a renal amyloidosis. So this is seen in patient 10 to 35 patient with endocrine spondylitis, and complication can lead to renal failure, hypertension, leading to chronic renal failure, and you have to ask for your nephrologist colleague. So endocrine spondylitis, that is joint, spine, and sacroiliac joint involvement extending proximally, cephalically, involving the thoracic spines. These are the local manifestation of the spine itself. And extra-apical manifestation including your eyes, your heart, your lungs, and the renal manifestation. These are the, and the skin, psoriatic rash are the cutaneous manifestations. So because of the, if we come back to the spine itself, because it is a continuous inflammatory process that involves the ligaments, your tendons, your joint capsule, and soft tissue surrounding the joints and joints of the spine. So whole, if you look at the vertebra, it is consists of the spine itself, its surrounding tissues, its joint capsule, tendons, and the ligaments. So all whole spine is inflamed and leading to they are damaged, they are calcified, and they fuse together as a joint. These spaces are replaced by bone, leading to reduced motion. Your patient cannot bend itself, and reduce motion of the neck and the low back. So if you look at the inflammatory process involving the leg, your spine itself, number one, your vertebral body, and your joint tissues involving the ligament, tendon, joint capsule, and they get inflamed and fused together, leading to reduce motion, especially at the back, side to side motion, bending forward, and involving the neck and the thoracic spine, leading to deformity and limited activity. So as a spine, they fuse and stiffness, the neck and the low back, they are lose their normal curve. And mid-back curve outwards lead to kyphosis, and flex bend forward of the leading to your patient will have very comma sign, that is the comma sign kyphosis, and the prominence of the thoracic spine. So leading to significant deformity. So inflammation of the small joints are also, especially the costovertebral joints and the collarbone, that can lead to expansion of the chest and your breathing problem, leading to apical lung fibrosis. So initially we discussed the extra-articular manifestation. Now more precisely the inflammation of the joint itself, which is the spine and the sacroiliac joints. And if you look at the generalized symptom, patient may have low-grade fever, may have generalized fatigue, may have aortitis. I told you, patient can present with the aortic regurgitation and they may history of low backache, or patient may have apical line fibrosis with shortness of breath, or may have supurated tuberculosis infection. So one disease presenting with the other clinical manifestation of other system, and ataxia of the sacral nerve, Roche sheath may be involved. So as with all seronegative arthropathies, the nail changes can also take place, that is called necrosis can be there. Okay, so young male with history of chronic backache, especially first in the morning, it gets better over the day, and they may have extra article manifestation. They may have inferior uveitis, iridocyclitis, aortic regurgitation because of aortitis, may have renal involvement in long-standing disease. But how you make a diagnosis? Patient may present when in the early phase of the disease, very initial phase of sacroiliitis, may have early morning stiffness and pain, low backache. If you make early diagnosis, you can prevent your patient from having extra-article manifestation and long-standing complication. Okay, if diagnosis is missed, patient will have complication, may have cardiac, may have renal, may have pulmonary, may have other manifestation leading to multiple organ damage. So objective of medicine is early diagnosis and intervene your patient as soon as possible to prevent later on complications. Like diabetes, if you make your glycemic control early diagnosis and don't let your patient having complications like strokes, MI, renal failure, or diabetic complications as other diseases, hypertension leading to complications like heart failure, renal failure, strokes, and all those. So whenever you have a patient, take a good history, do a clinical examination, and correlate the things. Some symptoms were a minor disease of a major, minor symptom of a major disease or major symptom of a minor disease. The patient may simply comes with he had a history of a backache for the last 3 4 years, relieved by some NSAIDs and painkillers. Now he has a cough with expectoration and there is a blood in the stomach. So he may have apical fibrosis, may have tuberculosis, and underlying diagnosis was including spondylitis. Another scenario, a patient may have history of chronic backache, young male, and now he says, I am short of breath after exercise and I have palpitation. If you examine, he had collapsing pulses. He has diastolic murmur on the aortic area. He has developed aortic regurgitation. Another patient, young male, he was fine, having chronic backache, uh, taking some painkiller and NSAIDs, now presents with swelling in the ankles. And he says, I wake up early morning, I have periorbital swelling. That means probably he has developed the proteinuria leading to edema. And if you make a diagnosis of nephrotic syndrome. And looking at the back, he had history of backache, and now probably he has developed chronic extra article manifestation like nephrotic syndrome. So he is now present with periorbital edema and swelling in the ankle area. So you just see there is a pitting edema, and you suspect he had good history, whatever the past history. He had chronic backache, now presenting with nephrotic syndrome. You go for proteinuria, go for albumin levels, go for cholesterol, and check the 24-hour unit protein for nephrotic syndrome. Another scenario, patient with the skin rash coming to the dermatology department and say, I have developed this rash, and the patient was asked, what was the, if you had any other problem? Yes, I was having backache for the last 3 4 years. I have this skin rash. So you have to think and correlate the things. Another patient may have a history of, comes to the eye department. He had very red eyes with hypopyon and complicated iridocyclitis and uveitis. And he says, do you have any problem? Yes, sir, I have backache last 3 4 years. I was taking some painkiller. I had an X-ray, and the X-ray is okay. That was the initial phase of X-ray. There was no, but you have to look for MRI. I'll discuss later on. So different mode of presentation of a disease can be a to different department, and you have to link the things to make a one diagnosis. Okay, so you suspect the disease, and what test would you do? Simple routine test, CBC, ESR may be raised, or he, because of chronic inflammatory process, he may have hyperchromic anemia and may have leukocytosis. And go for biochemistry. You can go for globulin levels, gamma globulins, and these are the. And okay, CRP is again maybe raised because of the inflammatory process. You will check for a patient may have peripheral joint involvement. You will check the root or the rheumatoid arthritis are affected. Most important, when you suspect the disease, you will ask for HLA-B27. That is the most specific and important test for patient in ankylosing spondylitis. Other tests you will see for extra article manifestation. You can have chest X-ray, you can have echocardiography, cardiograph, ECG. You can have proteinuria for the nephrotic syndrome. So at the same time, you will look for the patient primary disease and its extra articular complications. What are the complications of that patient? So if we do the X-ray of the spine itself and sacroiliac joints, you can get just X-ray of the sacroiliac joint epilateral view. You can go for scintigraphy. CT MRI is a very, very important test. You can see the early sacroiliitis, very early phase of sacroiliitis, very periosteal erosions, and it's the early inflammatory process. And you can go for extra-articular manifestations like CT chest to see the aortic aortitis and aortic distension. Blood test, I told you, you will go for HLB27, suspect the disease, and you go routine test and more specific test HLB27. X-ray chest can be done to see for scoliosis and other, and at the same time, apical lung fibrosis. Tomography and MRI of the sacral joint are the most specific. So these are the MRI of the sacral joint will reveal bilateral sacroiliitis in the early phase and the reliability of the testing. Schober test. This is the you do in your OPD department. This is a very useful clinical measure of the flexion of the lumbar spine performed during examination. So patient come to you with backache, young man with backache, early morning stiffness, and gets better, and he has limited back motion, difficulty in praying, especially when going to the poo. He has very bad pain and limitation of forward flexion. And you do the Schober test. How you do the Schober test is very simple. Patient is standing upright. Two marks are made on the patient back, one at the level of the sacral dimple, that is at the fifth lumbar spine, and the other at the 10 centimeter above. If we look at the sacral dimple, they are here at the level of the fifth lumbar spine, and you put a measuring tape here, make a mark here, and 10 centimeter above you make a mark here. So this is the normal spinal length which we measure during standing and then after bending forward. So normally what happens is this dimple of the sacral spine and at the fifth lumbar spine, sorry, yeah, fifth lumbar spine and the tensor. So you will take two marks, one at the dimple and one above at the 10 centimeter. Ask a patient to bend forward. Now patient is bending forward and you see the distance between the two marks is measured. This mark, the dimple and the spine which you had this mark. If it is normally, what happens is your overnight skin will have stretch of 15 centimeters. They will add of 5 centimeter extra. And value less than this is a indicative of reduced lumbar motility. Means the patient is joints are stiff and he cannot bend and cannot flex the joint, and it is a limited movement. So there is a no 10, maybe 10 at the same time, but normally it will go to 15 because the flexion of the spine, your flexion will be more spine more flexible, and you can have a 15 centimeter of these marks. So the increase in the marks that indicate is a normal, but reduced movement, that means your spine is stiff and it is a Schober test is positive. So I tell you, just explain you again. True dimple of the spine at the L5 level and 10 centimeter to second mark. Ask the patient to bend forward. In ankylosing spondylitis, if you have a stiff joints, the spines are sclerosed and they have the loss of their flexion movement. The patient will, there will be no increase. There will be no increase in the distance which was measured here, 10 centimeter, 10 centimeter. But normally what happens is it can go up to 15 centimeter because of the lumbar flexion and its flexibility. So increase in this length is better, is a normal flexion, and reduction in this is bad. That means your spines are fused together and they have a limited movement. So this is the Schober test. I hope you understand. So limitation of flexion and reduction of the Distance means your spine is diseased. Increase in flexion, and the distance more than 15, that means your spine is okay. Okay, complications I told you can lead to kyphosis and osteoporosis, and cord-icona syndrome may have complication where the nerves at the bottom of the spine become compressed and causes pain, numbness in the lower back and buttock, and legs are weak. They may have flaccid paralysis, and patient may have urinary incontinence because of the cord compression, cord-icona syndrome. That means your spines are ankylosed, they are having a compression of the spinal processes, compression of the spinal cord leading to cord-icona syndrome with loss of sensation, loss of movement, and urinary incontinence leading to cord compression. This is the rather a surgical emergency when you have any numbness, you have any urinary incontinence, or you have any weakness in your legs. So this is a classical picture of ankylosing spondylitis. You can see the four kyphosis. Your back is just kyphosed as a comma squared sign, and you can see the calcification and stripping of the lumbar your axial spines and leading to calcification, that is a bamboo spine. Okay, so what is the treatment? So you have patient with chronic backache, they have early phase of ankylosing spondylitis with sacroiliitis, or they have ankylosing spondylitis with X-article manifestation. What can you do for that? Your patient is here. So there are three types of medication used for ankylosing spondylitis. I told you early diagnosis and early intervention. Don't let your patient to go into extra article complications like cardiac, renal, and pulmonary and cutaneous manifestation. So the treatment of thumb is the anti-inflammatory drugs. You can use NSAID, aspirin, ibuprofen, phyllopetalone, indomethacin. They're all anti-inflammatory drugs, and including the COX-2 inhibitors. They reduce inflammation and the pain. So anti-inflammatory drugs, they reduce the inflammatory process of the sacroiliitis and spinal inflammation, ligaments, all the spine your ligaments, your joints, they inflame, they reduce inflammation and reduce the later on complication. So anti-inflammatory for pain relief and reduce the inflammation. Disease modifying anti-inflammatory drugs, these are the second class of drugs which are used because I told you it is an inflammatory because of some autoimmune process. So you can use as immune modulating drugs like cyclosporin, methotrexate, sulfasalazine, and even steroids to reduce the immune response of the body because of some inflammatory trigger. These are the new drugs which are tumor necrosis factor blocker antagonists. These are the drugs which are especially infliximab is given 5 milligram per kilogram body weight, two injections once a month. So infliximab 5 milligram per kilogram body weight is a very good drug to prevent the early complication, and especially people who are very aggressive disease, high CSR, CRP, anemia, very severe sacroiliitis and aggressive disease, you can use the TNF blockers. Is a infliximab 5 milligram per kilogram body weight. You can use this for two injections every month. And next is your drugs which are slope crossing, and majority of the clinical trials have shown they are you must what you have to do is you have to reduce the inflammation of the joints and the major clinical cases. They have also shown to be very effective, and surgical management regarding your deformities and osteotomy for osteodesmophyte, osteophytes which are formed and they lead to calcification of the ligaments, that can be done with some surgical procedures, and occasionally you can go for arthroplasty or hip or joint replacement therapies. Okay, what should be the early nursing and the education of the patient? So educate the patient about the disease, because it is a disease which usually involves the sacroiliac joint, your spines, leading to local deformities of the joints, limited movement and pains. Then it can have extra articular manifestations. So you have to explain to your patient it is a disease, it is a syndrome that can give you multi-systemic problem. So baseline routine examination can be done, routine investigation can be done, and patient can be look for any extra articular manifestation. The pain should be managed by good medication, by NSAID. Patient should be asked to take heat therapy, massage, and gentle exercise. Excessive physical exertion during episode. If you have acute sacroiliitis, don't exert too much, because it is a acute inflamed sacroiliac joints that can be worse by excessive movement and expression. Positioning of the important is very, because these are the patients who go into severe kyphosis and deformity of the spines. So rest is very, very important, and the patient should take a firm mattress, and pillows should be avoided, because once you take the very hyperextension of the neck, that can lead to a deformity worse, and the patient should sleep on a back and avoid the encourage the flexion deformity, because they should be on supine position. So supine sleep would be better rather than a side-to-side sleep, because they help in avoiding the postural problem. And posture training emphasize avoid flexion, heavy lifting, and prolonged walking, standing, or sitting. So these are the patients who are properly managed by rehabilitation and proper nursing care and exercise and all their physiotherapy. So this is the another picture of a normal spine, where you can see the good spines with intervertebral discs and the ligaments and the spinal processes. Here you look at the spondylitis, there is a diseased spine with the loss of their periarticular erosions and damage, and you have inflamed joints. Your vertebra are lost, and there is a damaged joints, leading to calcification, kyphosis, and deformities, and leading to sometimes bamboo spine. Again, picture, you can see the normal spine. There is a initial phase of inflammation. Then you can see there is a spine become fused together and lead to limited motion, limited activity, and later on deformities. This is the classical picture of advanced ankylosing spondylitis. You can see the patient who have a thoracic spine are more prominent, and they have a severe kyphosis of the lumbar spine. So this is a comma sign. You can see the patient who have a deformity, very bad kyphosis and deformity of the ankylosing spondylitis. So basically, your objective is make early diagnosis, take a good history, do a clinical examination, and the Schober test is a very good test to check the flexion of the spine in your OPD department. And you can make a mark at the spinal nipple, and you can check the spinal flexion. Less than 10 would be bad, but more than up to 15 is a good. There is a good flexion of the spine. So this is the late end part of the story. You can see the man with the deformity. He probably started disease at the age of 15, maybe 20, 25, up to 30 years, and up to 50 years he has gone this type of posture. So disease process, early detection, early treatment, and education of the patient is very, very important, and look for the extra articular manifestation. Okay, thank you very much. I hope you understand the topic, and I'll see you maybe next week with a new topic. Stay home, stay safe, and look after yourself. Thank you very much. Allah Hafiz.
सुनाओ